Dear chairs, dear audience, my name is Patrik Kreuter and I'd like to introduce my PhD topic, the latest advancements in digital orthodontics. I'm a first-year resident at the Department of Pediatric Dentistry and Orthodontics. My supervisors are Noemi Rózsa and Dorottya Bányai, my SMS is Petrana Martinakova, and my statistician is Silvia Kisdala. My vision is to help more people smile confidently, and my mission is to contribute to the development of orthodontic guidelines providing high-quality treatments without compromise. I have two ongoing projects. Both of them aim to compare the differences in adverse effects between traditional and digital orthodontic treatments. My first project is titled Investigating the Differences in Root Resorption between Fixed Appliances and Aligners in Permanent Dentition, which is a systematic review and meta-analysis. Fixed orthodontic appliances often cause aesthetic and hygienic difficulties during the treatment. However, aligner treatments are more comfortable and aesthetic with less treatment-associated periodontal risk. One of the most common orthodontic treatment adverse effects is external apical root resorption, which is an irreversible hard tissue loss of the teeth during the treatment. It can occur in up to 90% of the cases. Aligners previously showed lower prevalence and severity on radiographs for external apical root resorption. However, more accurate CBCT studies have been conducted only recently. Our aim is to investigate the differences between aligners and fixed appliances in terms of root resorption. My clinical question is, how do aligners perform in terms of external apical root resorption compared to fixed appliances? I use the PICO framework where the population is patients with permanent dentition. The intervention is aligners compared to fixed appliances, either conventional or self-ligating fixed appliances. The primary outcome is root resorption measured as a root length change on CBCT records, while the secondary outcome is the same measurement on radiographs. Our hypothesis is that aligner therapy causes less severe root resorption. I've conducted my systematic search on the 13th of November in 4 databases with the following search key. After about 7,000 hits, I finished the duplicate removal, the title abstract, and full text selection, and now we have 7 eligible full texts. We were able to analyze 2 primary outcomes quantitatively from these articles, the root length change of central and lateral incisors on CBCT recordings. In the following slides, I would like to show you my preliminary results. The first 2 forest plots show the upper central incisor length change on CBCT studies. The outcome measurement was a millimeter length change of the teeth, and based on previous studies, we can say that below 1 millimeter, the root resorption doesn't affect the longevity of the teeth. It's clinically not relevant. In the first forest plot, I've compared 4 retrospective cohort studies population with almost 200 patients. With the I-square of 59%, we can say that there was a high heterogeneity. This can be due to the differences in demographics and also the treated malocclusions and the treatment time. In this case, I've compared aligner therapy with conventional fixed appliances, and the mean difference of 0.51 millimeter is below the 1 millimeter threshold, so we can state that it's clinically not a significant difference, and also we can see that it's statistically insignificant. However, we can see a clear tendency that suggests that fixed appliances may cause more severe root resorption. Also, it's important to note that all the clinically significant changes were seen in the fixed appliance groups. The second forest plot has the same outcome measurement, but here the aligner therapy was compared to self-ligating fixed appliances. 3 retrospective cohort studies were included with almost 108 patients. The I-square value was almost the same, and the same reasons can be told for the heterogeneity. Here we have an even smaller mean difference, suggesting that there is no significant difference between the 2 treatment methods. However, it's important to note that in this case, the aligner group had the only clinically significant difference. My last forest plot is about the upper lateral incisor length, so another tooth type. The same measurements were conducted, the CBCT root length changes. Here I've compared the aligner therapy to the conventional fixed appliance, and 3 retrospective cohort studies were included with almost 150 patients. The I-square of 79% shows that there was an even higher heterogeneity. This can be due to the different malocclusions treated. Here, the 0.62 millimeter change is also below the 1 millimeter clinically significant threshold. However, the tendency is the same as on the first forest plot, and the 0.62 millimeter is about 20% higher than the first one, which suggests that the upper lateral incisors may be more prone to root resorption, which is suggested by previous studies as well. Also, all the clinically relevant changes were in the fixed appliance group. It's going to be the first quantitative analysis based purely on CBCT studies, and it includes only 2-arm studies, and most of them are from the past 3 years. However, it's important to highlight that these are only retrospective studies. They have high heterogeneity, and most of them present at least a moderate risk of bias. The conclusion, based on the preliminary results, is that aligners and fixed appliances cause similar root resorption. And the implication for practice is that both interventions can be used for patients who are not prone to root resorption, so they don't present the risk factors. Self-ligating appliances and aligners may cause less severe root resorption, and upper lateral incisor may be more prone to root resorption. The implication for research is that there's a lack of high-quality RCTs, and further studies should check the differences between different types of fixed appliances. Also, one of the studies included 3D volumetric measurements, which may be more accurate in this topic than longitudinal measurements. Here you can see my progress. I started to write the manuscript with the methods parts finished. My second project is titled Analyzing the Failure Rate and Adverse Effects with Indirectly versus Directly Bonded Orthodontic Brackets. This is a systematic review and meta-analysis as well. The conventional bonding of multi-bond appliances requires high precision, as the misplacement of orthodontic brackets can cause unwanted tooth movement. Indirect bonding is more predictable and precise and decreases chair time as well. Several articles show controversy regarding the adverse effects between these two modalities, and since the latest reviews emphasize that there's a weak evidence available, new studies have been conducted, including RCTs. The aim of our study is to objectively compare these two methods in terms of the aforementioned outcomes. The clinical question is, what is the performance of indirectly versus directly bonded brackets in terms of adverse effects? The PICO framework is used here as well. The population is multi-bond appliances. The intervention is indirect bonding compared to direct bonding. The primary outcome is debonding, so the loss of brackets. The secondary outcomes are plaque accumulation and formation of white spot lesions. Our hypothesis is that indirect bonding is non-inferior in terms of these adverse effects compared to direct bonding. The clinical implication would be less chair time with similar occurrence of adverse effects. I've conducted my preliminary research with the following search key and recognized 4 key articles, and now I'm working on my Prospero registration. Here you can see a summary of my 2 ongoing projects. My aim is to compare the digital and conventional treatment methods in terms of adverse effects. I would like to thank you for your attention with this quote from Spinoza: "The highest activity a human being can attain is learning for understanding, because to understand is to be free." Thank you for your attention.
Regarding your second topic, how are you going to diagnose the white spot lesions?
Thank you for the question. So fluorescence is the most commonly used diagnostic tool for this. We will check what kind of data is provided by the articles, but as I saw previously, mainly the methods based on fluorescence are available both for quantitative and qualitative measurements.
In the articles, the authors describe the difficulty of the orthodontic treatment of the aligners and the regular.
Yes, thank you for the question. It's a very important one. Thankfully, most articles use the American Board of Orthodontics discrepancy index to describe the severity of the cases, and the 2 groups were matched. But sadly, between the studies, it's hard to match it because both the discrepancy index scores were different and also the treated malocclusions. So class 1, class 2, and class 3 patients, based on the angle diagnostics, were all included in this meta-analysis, and this makes makes it hard to compare them because different tooth movements cause different degrees of root resorption. So it's a main reason for heterogeneity, yes.
And you don't have enough result to make subgroups?
Not yet, sadly not.
Talking about fixed appliances, what do you think? Is there any difference between the conventional and the self-ligating appliances?
Yes, thank you. If I go back in the presentation, I may be able to show it more precisely. So the main difference between the two fixed appliances is the ligation, so how the metallic arch wire is fixed in the slots of the brackets. Here you can see a conventional appliance, and here elastic ligatures are used to fix the arch wire into the brackets. And as the elastic ligatures have higher friction, more force needs to be used for the tooth movements. However, self-ligating appliances use brackets which don't need solo ligatures. They have a lock system built inside the bracket, and as the whole bracket is from metal and the arch wire is from metal as well, there's less friction, so less force needs to be applied to the teeth, thus less root resorption occurs. Probably that's the reason.
Thank you. Are you planning to subgrouping these?
Yes, we don't have enough data to subgroup, but we are planning to remake our forest plots so we can present them both.
My question about the resorption less than 1 millimeter is clinically insignificant, and this is measured on CBCTs, so this is of true value. Like, is that reversible, or why it is insignificant?
Thank you for the question. So yes, one of the main reasons why it can be significant is that it's irreversible. So there's no known treatment method to solve root resorption. And while the 1 millimeter may not cause any symptoms, but the re-orthodontic treatment of the patients may cause more severe root resorption. And actually, there isn't a non-arbitrary number in the literature which states that from which degree we can say that it's clinically significant. Sadly, it's an arbitrary number, but it was used in previous studies as well.
Your first project, given that only retrospective observational studies exist and the effect direction seems to be parallel, supporting the intervention or favoring the intervention, why do you think a meta-analysis is the correct study design to answer your research question?
Thank you for the question. It's a tough one. So actually, there were previous meta-analyses on this topic, and all the meta-analyses highlighted that when they use both radiographs and CBCTs, there was a risk of distortion of the results because they use both methodologies, and as we know, radiographs aren't precise enough to show the differences. So when they pull together CBCTs and radiographs, the results may be biased because of the different treatment methods. Right now, the systematic review meta-analysis may not be the best method for comparing these, as there isn't enough evidence. It's been only this study has been only conducted in the past few years, and only one RCT was available, but sadly that was with radiographs, so we couldn't include it in the quantitative analysis. So our implication would be for research that there are more RCTs needs to be done on this topic with CBCT recordings, and the next meta-analysis, which would make sense clinically, should be done after these studies are conducted.